Hello, this is part 12 of our systematic approach to ECGs. And in this part we're going to focus on the ST segments and T waves. So this is the final section of our systematic approach when evaluating an ECG. So first let's talk about the ST segments. And when we look at the ST segments, we want to focus on two things. Is there evidence of ST elevation, or is there evidence of ST depression? When you're determining whether there's evidence of ST elevation or depression, you need to identify the J point. Now there is a lot of disagreement in general among cardiologists, emergency physicians, and other doctors whether you should use the J point or some trailing point after the J point, like one small box or 40 milliseconds. But in general, it's easiest to use the J point, and most people do say that using the J point is okay. So we want to identify the J point, and the J point is the point at which the QRS complex changes into what should be our baseline ST area. And that is where you see a change in the slope of the QRS complex. So in this initial picture, you can see the J point, the change in the slope there. In the second picture, you can see the change in that slope again. And then in that final picture on the right-hand side of the screen, you can see that that J point is elevated because the QRS comes up, but then it changes the slope and levels off. So we want to identify that J point. And then we want to use that J point to compare our ST segment to our TP segment. So we identify the J point, and then we identify that nice flat baseline, or the TP segment. And in this case, you can see that the J point is higher, significantly higher, than the TP segment. Now, just like with an evaluation of a wide QRS, it's not enough to just identify that the ST segment is elevated. You have to have a differential diagnosis for why that elevation is important. Because most people immediately think, oh, I've got ST elevation, and that means I've got an acute myocardial infarction. But in fact, that's not the case. Over 80% of the time that you look at an ECG and see ST elevation, it is not from an acute myocardial infarction. It's from another condition. So what are the 8 things I like to think about when I see ST elevation on an ECG? I've listed them here. And I always start with thinking about an acute myocardial infarction because that's one of the most important to identify early. But other things such as early repolarization, formerly known as benign early repolarization, bundle branch blocks, which we talk about separately, Prinzmetal's angina or vasospasm, pericarditis, left ventricular aneurysm, left ventricular hypertrophy, and Brugada syndrome. We do talk about the AMI and the bundle branch blocks separately, and those are important ones to identify. Take a look at this ECG and see if you can identify any ST elevation. So again, you should be able to quickly see that there's ST elevation in the inferior leads, in leads 2, 3, and AVF. But when you identify ST elevation on an ECG, you still want to use your systematic approach and be going through each section. And so that means we're going to look at all the ST segments, and that means we're going to look for ST depression as well. And when you do that, you see ST depression in lead 1 and AVL. So what does that mean? Why do we have both ST elevation and ST depression on the same ECG? Well, one potential cause is that these ST depressions are called reciprocal changes. So reciprocal changes are changes that you can see on an ECG where the ST segment is depressed in the setting of an acute myocardial infarction. And I like to use the mnemonic PALES to help me remember where I will see the ST depressions when I have ST elevation. So if I have a posterior ST elevation MI, I will see anterior, so leads V1, V2, V3, reciprocal changes or ST depressions. If I have anterior ST elevation MI, I'm going to look in the inferior leads for those reciprocal ST depressions. The same is true if I have an inferior ST elevation MI. I'm going to look in the lateral leads, and for the lateral leads, I'm going to look for that depression in the septal leads. Why is it important to look for? Well, it increases the specificity of that ST elevation as being due to an acute myocardial infarction if you have reciprocal ST depressions. Just like with ST elevation, we have to think about our causes or our differential diagnosis of why we have ST elevation or ST depression. And so we talked already about reciprocal changes, so myocardial ischemia or infarction could be a reason for ST depression. But there's other causes as well, such as left ventricular hypertrophy, bundle branch blocks, digitalis effect can frequently cause a scooped ST segment, pulmonary embolus can cause heart strain and ST segment depression, and then hyperkalemia and hypokalemia as well. So as we move from the ST segments, we want to do our last section, which is looking at the T waves. And when I look at the T waves, the things I really want to focus on are there deep symmetric T wave inversions? Because if you see deep symmetric T wave inversions, especially in the anterior leads, this can be a sign of ischemia or a pulmonary embolus. And then you also want to look at those T waves. If they're tall or peaked, that can be concerning as well. They're called hyperacute T waves if you have large, tall, semi-peaked T waves early on in a patient with ACS or acute coronary syndrome type symptoms. Or in the ones that are very tall and very sharp or peaked, that can also be a sign of hyperkalemia. So when we look at the T waves, focus on, are there deep symmetric inversions or are they tall and peaked? So in summary, our ST segments and T waves. We want to remember the differential diagnosis and our 8 causes of an ST segment elevation in depression. And then we want to look for those deep symmetric T waves or peaked T waves. Thank you.